The following podcast is part of a certified educational activity titled Exploring New Paradigms in Transthyretin Cardiac Amyloidosis Care, Experts versus AI. Access the entire activity and complete the post-test at peerview.com/UBF860. Downloadable slides and practice aids are also available.
Hello, this is Matt Moore from Columbia University Irving Medical Center and New York Presbyterian Hospital in New York. I'd like to welcome you to today's webcast entitled Exploring New Paradigms in Transthyretin Cardiac Amyloidosis Care, Experts versus AI. Joining me is my esteemed colleague, Professor Julian Gilmore from the University College London Center for Amyloidosis and the National Amyloidosis Center in London, England. Welcome, Julian.
Thank you, Matt. Hi, nice to see you.
The goals for today. Well, during the presentation, you will hopefully learn that ATTR amyloidosis has widely variable clinical phenotypes and often requires multidisciplinary team management. You'll learn that the diagnosis of ATTR-CA by cardiac scintigraphy is only valid if monoclonal proteins are not present. And finally, we'll discuss targeted therapies for ATTR-CA that slow disease progression, all of which are most effective if initiated early in the disease course. How will we incorporate AI into this activity? We will ask AI chatbot to review the care of patients who've been referred with suspected ATTR-CA, walking through each step of the diagnosis and treatment. So I'd like to turn it over to my colleague, Dr. Julian Gilmore, who will focus on Spotlight on ATTR, recognizing patterns to avoid misdiagnosis. Take it away, Julian.
Thank you very much, Matt. So amyloidosis can affect the heart or is characterized by infiltration of amyloid fibrils in the heart. And the fibrils can be composed either of light chains derived from a monoclonal, usually plasma cell dyscrasia, which is formed in the bone marrow, or the amyloid fibrils can be derived from the TTR protein, which is produced almost exclusively in the liver. In ATTR amyloidosis, in which the TTR protein is the amyloid fibril, that protein may be mutated, and that's hereditary or variant ATTR amyloidosis, or it may be what we call wild type, in other words, with a normal sequence, and that's generally age-related. Both types of amyloid affect the heart, as we heard, but there are some differences in that AL cardiac amyloidosis doesn't often affect orthopedic tissues, and in wild-type ATTR amyloidosis, certainly the kidneys are not typically affected by, or certainly not infiltrated by amyloid. And in the variant ATTR amyloidosis, the kidneys are very infrequently involved by the condition. There are more than 130 mutations in the TTR gene that can give rise to hereditary ATTR amyloidosis, and the dominant features of ATTR amyloidosis tend to be either the cardiac features or the neurological features. And there are certain mutations or a particular mutation, the V30M mutation, which essentially, if it's early onset, usually in patients from Portugal, causes a predominant and pretty much isolated neurological syndrome. There are other mutations, including most of the mutations that are common in North America and in the UK, including the T60A, the V122I, which cause a predominant cardiac phenotype. Having said that, pretty much every one of the 130 mutations can give a mixed phenotype, although the vast majority will have dominant cardiac features or dominant neurological features. So this is a study that was conducted by Dr. Ruberg, SCAN-MP. It was a prospective multi-center cross-sectional cohort study conducted between 2019 and 2024 in the US. And the primary inclusion criteria were age over 60, Black or Hispanic origin, diagnosed heart failure and an LV wall thickness of at least 12 millimeters with an LV ejection fraction of more than 30%. And what this study shows is that ATTR-CA is not rare among older adults with heart failure in the United States. And you can see that aged over 75, the prevalence of ATTR-CA is between 10 and 15%. And amongst Black men over 75 years old, the prevalence is as high as between 15 and 20%. So the clinical manifestations of ATTR amyloidosis can really be divided into cardiac and neuropathic. The cardiac manifestations include heart failure, atrial fibrillation, bradyarrhythmias, and conduction abnormalities often requiring insertion of pacemakers. The neuropathic features include peripheral neuropathic features, so amyloid polyneuropathy, which includes pain and weakness in the upper and lower limbs, usually starts in the lower limbs, and autonomic neuropathy, which includes orthostatic hypotension, intolerance to blood pressure medications, chronic bowel problems, often starting with alternating diarrhea and constipation and progressing to chronic diarrhea, and they include erectile function as well as a feature of autonomic dysfunction. The other feature of ATTR amyloidosis is musculoskeletal manifestations, which often predate the onset of the cardiac or neuropathic disease, and that includes bilateral carpal tunnel syndrome, back pain caused by lumbar canal stenosis or spinal stenosis, ruptured biceps tendon, giving the Popeye sign, and then shoulder, knee, and hip pain, often requiring surgery, although that's obviously very non-specific, particularly in the age group of patients that are susceptible to this disease. And another musculoskeletal feature of the condition is trigger finger. So here is a diagnostic algorithm for cardiac amyloidosis, and essentially, if one has clues from the history, an ECG, and particularly an echocardiogram or a cardiac MRI scan, if one suspects cardiac amyloidosis on the basis of those imaging techniques and the clinical history, the next stage is really to look for evidence of a monoclonal protein, and that includes doing 3 tests: the serum free light chain assay, the serum immunofixation, electrophoresis, and immunofixation. It's important to mention that immunofixation is more sensitive than electrophoresis and is an important component of that assay. And then urine electrophoresis and immunofixation. If there is no monoclonal protein and one undertakes a PYP, or in the UK, a DPD scan, with SPECT, and shows that there is myocardial uptake which is greater than or equal to the uptake in the bones. In other words, Perugini grade 2 or 3 uptake on a PYP or DPD scan, then in the absence of a monoclonal protein, one can confidently make the diagnosis of ATTR-CA. And one is then left to undertake genotyping to differentiate between the wild type and the hereditary condition. If there's no monoclonal protein and the PYP or DPD scan is negative, that in itself makes cardiac amyloidosis very unlikely, because one has effectively all but excluded AL amyloidosis on the basis of the monoclonal protein, and all but excluded ATTR amyloidosis on the basis of the PYP or DPD scan. There are a few exceptions with rare variants that have less uptake than expected on a PYP scan, but in the whole, that makes cardiac amyloidosis very unlikely. At the other end of the spectrum, if there is a monoclonal protein, then one really has to suspect AL amyloidosis in the heart. And at that stage, the important thing is to undertake a biopsy to determine whether a patient has AL amyloidosis in the heart or indeed might have ATTR amyloidosis with an incidental monoclonal gammopathy, which is not uncommon in this older age group. I mentioned that at the final stage of diagnosing ATTR-CA, one needs to differentiate between the hereditary condition and the wild type or acquired condition. This is also true for other cardiomyopathies in the context of cardiologists managing cardiomyopathies. And essentially, if one makes a clinical diagnosis of cardiomyopathy, cardiologists will generally undertake genetic evaluation based on the phenotype and family history, and then they will decide on a genetic testing strategy. If one has made a diagnosis of ATTR-CA, then obviously one would typically organize single gene testing of the TTR gene, but in an unspecified cardiomyopathy, one would generally run a cardiomyopathy gene panel, as it were. And then all that is left to do is to interpret the genetic test results and then return the results to patient and their families, and potentially organize family screening if it's felt to be relevant. So I'm going to present a case that was referred to us here at our national center in the UK. It's a case of a 68-year-old woman who was referred, and I draw your attention to the referral note at the bottom. I would be obliged if she could be considered for genetic counseling and testing, as well as tafamidis treatment for her ATTR amyloidosis. So she was referred as a case of ATTR amyloidosis. And her history was that in October 2024, she started to experience breathlessness. And in November, she was admitted with a left MCA territory ischemic cardiovascular accident for which she was thrombolized. She had an echocardiogram that was suggestive of cardiac amyloidosis and showed preserved LV ejection fraction and an NT-proBNP of over 3,000. She had a cardiac MRI scan a month later, and that was absolutely characteristic of cardiac amyloidosis, and a DPD scan that was perigeny grade 2. Her transthoracic echocardiogram didn't show any intracardiac thrombus, and she was treated with heart failure medications and anticoagulation. And shortly afterwards, she reported progressively worsening dyspnea. She was in NYHA functional class 2. Her examination showed a clinical frailty score of 4. She had macroglossia on clinical examination, and she was hypotensive with a blood pressure that you can see there. There was no postural blood pressure drop. Her 6-minute walk test was 207 meters, which is 47% of that expected for a woman of her age. You can see her test results there, and I draw your attention to her serum free light chain assay, which showed a kappa serum free light chain concentration of 410.2 milligrams per liter and a lambda of 8.5, which results in a kappa lambda ratio that's very, very abnormal of 48.3. And that indicates that she has a monoclonal protein in the bloodstream. Her NT-proBNP, only a few months after the first test, had risen to 14,678, and her echocardiogram was absolutely characteristic of cardiac amyloidosis. This is just to highlight the fact that her kappa lambda ratio on the serum free light chain assay was abnormal, and you can see the reference values for different levels of GFR. It's important to say that both kappa and lambda light chains are retained in patients with renal impairment, so they both will typically go up, but the kappa is retained rather more than the lambda, so that the ratio will also go up as renal function declines. And you can see at the bottom there some revised reference intervals for the normal polyclonal ratio depending on GFR. So our patient's ratio was 48, and you can see that that's markedly abnormal regardless of GFR. This is a review of her imaging. On the left, you can see the anterior whole body DPD scan, with the SPECT there in the middle panel, and that shows uptake that is less than bone and some uptake in the septum on the SPECT. So it's myocardial, it's less than bone, so it's a perigeny grade 1 scan. And the CMR on the right shows diffuse subendocardial late gadolinium enhancement. We have a woman with a plasma cell dyscrasia who has grade 1 uptake on a DPD scan and characteristic uh, features on a cardiac MRI and echocardiogram of cardiac amyloidosis and very high biomarkers. We undertook a fat aspirate, and the fat aspirate actually showed AL kappa type subtype amyloid consistent with her plasma cell dyscrasia. Importantly, her TTR and APOA1 genotype were normal, wild type, so there were no mutations. So we were confident in making a diagnosis of systemic AL amyloidosis with dominant cardiac involvement. And actually, her biomarkers indicated Mayo stage 3B disease. So she has a kappa light chain monoclonal gammopathy and systemic AL amyloidosis, despite the findings of an abnormal DPD scan, and she was treated with DARA-CVD chemotherapy, and there's absolutely no role for tafamidis or treatments for ATTR amyloidosis in this condition, which is a totally different condition. So just to recap the essential criteria to make a non-biopsy diagnosis, a diagnosis in the absence of a biopsy, one needs the appropriate clinical suspicion, one needs the characteristic findings on cardiac imaging, either an echocardiogram or a cardiac MRI scan, one needs a grade 2 or 3 DPD scan or PYP scan, and the absence of a monoclonal protein using all 3 tests: serum immunofixation, urine immunofixation, and serum free light chain assay. Matt, over to you to talk about evidence at a glance, understanding the trial data shaping ATTR-CA care.
Thanks, Julian. That was outstanding, as usual. So let's just touch base a little bit about pillars of care for heart failure in general and how they apply to patients with a cardiac amyloid. All the way to the right is the important point that atrial fibrillation is quite prevalent in patients with cardiac amyloidosis, and they get anticoagulated regardless of their CHEDS-VAS score. Regarding the 4 pillars of therapy, we've learned that MRAs across the spectrum of ejection fraction, and same with SGLT2s, are quite beneficial therapies. Julian and his colleagues at the NAC showed in a propensity-matched analysis that SGLT2 inhibitors had quite favorable effects on hard endpoints and in patients who were receiving these agents compared to age, gender, and carefully matched patients who were not. ACE inhibitors, ARBs, and ARNIs don't have a significant role, and often patients have concomitant autonomic dysfunction, making them intolerant to such therapies. And the role for beta blockers is unclear. We're pretty convinced that high-dose vasodilatory beta blockers are harmful in such patients, but there's evidence to show that low-dose beta blockers using either metoprolol or bisoprolol, especially in patients with reduced ejection fractions from the NAC data, were associated with better outcomes. And so low-dose beta blockers may be reasonable and often are used to concomitantly control heart rate in patients with atrial fibrillation. The emerging therapies for TTR amyloid has really evolved from a great understanding of the underlying pathobiological processes. As we heard, TTR is a protein either produced in a normal or variant form by the liver on chromosome 18. It's a homotetramer or 4-leaf-like clover. And in the setting of either advancing age or variants in TTR, the protein can become unstable. There's also proteolytic cleavage that could be operative, resulting in monomers or oligomers that can form amyloid fibrils and deposit in the organs. And once you understand this biology, you can elucidate preventive or treatment strategies, if you will. The first was liver transplant, which we no longer use, but we now have gene silencers, plenitersen, patisiran, and vutrisiran, that can stop the hepatic production and meaningfully improve outcomes in patients. And we have TTR stabilizers for many years, tafamidis, now acoramidis, and off-label diflunisal that stabilize the protein. And amyloid degradation is an active area of investigation with no therapy yet on the market. The ATTR-ACT trial first showed that stabilization was effective. It was a trial of 441 patients, including wild-type and variant patients. They received both 20 and 80 milligrams of tafamidis, which was pooled, comparing those on tafamidis versus those on placebo. And we saw quite surprising 13% absolute risk reduction in mortality, which, as you can see from the survival analyses there, tend to emerge at about 18 months. The mortality effects in all of the trials are somewhat delayed and don't occur immediately, further emphasizing the importance of early diagnosis. And there was demonstrable effects on mortality with a number needed to treat of 7.5 to prevent a death, and a reduction in CV hospitalizations with an NNT of about 4 to prevent one hospitalization over 12 months. Similarly, tafamidis in the ATTR-ACT trial slowed the decline in functional capacity and quality of life, didn't improve things, and you can see the differences there emerging earlier than the mortality effect. We have a new agent on the market as of November of last year in the U.S., acoramidis, that was studied in the ATTRibute-CM trial, again, a phase 3 trial that was slightly larger using acoramidis at 800 milligrams twice daily. Patients were randomized in this trial 2-to-1 to receive active therapy versus placebo, and most patients had wild-type disease, though there were patients with variant as well. During the first 12 months, they didn't allow tafamidis therapy, and there was some tafamidis drop-in, though I don't think that meaning affected any of the outcomes. And the original approach was a hierarchical 4-component Finkelstein-Schoenfeld method that strongly favored acoramidis. Way more than half of the wins were related to all-cause mortality and CV hospitalizations. And you can see here the curves that show significant effects both during the trial and during the open-label extension, with a dramatic 50%, if you will, reduction in the rate of first CV hospitalization in the population who received acoramidis versus placebo. We've also learned that TTR stabilizers will result in increases in serum transthyretin concentrations, as shown here in the ATTRibute-CM trial. Those have recently been associated with improvements in outcomes, and it's a nice way to show the patient in the clinic by serial testing that the drug is effective. And similar to the ATTR-ACT trial, there was a slowing of the decline in the 6-minute hall walk functional capacity in KCCQ, and a slowing of the rise in the rate of biomarker increases that were seen with this example, NT-proBNP. A third agent working in a different mechanism of action is vutrisiran, a silencer next generation that's administered subcutaneously, and this was studied in the landmark HELIOS-B trial, presented and published in the New England Journal by Mariano Fontana. Here we randomized 655 patients, 1-to-1 to receive vutrisiran subcutaneously, 25 milligrams every 3 months versus placebo. And the primary endpoint was a composite of death from any cause and recurrent CV hospitalizations. Notably, a large percentage of these patients were concomitantly receiving tafamidis at baseline, and an additional 20% almost dropped in receiving tafamidis during the clinical trial. And as you can see, there were significant effects on the time to first event in the overall population, and reduction in mortality in the overall population treated with vutrisiran versus a placebo. And the opposite is seen with a silencer. To remind you, these are drugs that decrease the serum transthyretin concentration, and that's their mechanism of action. And there was an 81% decline on average in the group receiving vutrisiran. Again, we see a slowing of the decline in 6-minute hall walk in KCCQ, and a significant attenuation in the rise of cardiac biomarkers, in this case, the NT-proBNP. Those similar effects were seen with troponin. Across multiple pre-specified subgroups shown in this forest plot, there was really absence of heterogeneity of the clinical benefit of vutrisiran. And as you can see, particularly in the tafamidis cohort, those were not receiving or not receiving tafamidis, there was no evidence of heterogeneity suggesting a treatment effect across the populations. Notably, we've made tremendous progress in this particular field, evidenced by examining, if you will, the 3 trials that I just mentioned. While the age hasn't changed very much, trials have gotten a little bit larger. We've unfortunately got less successful at enrolling variant patients, which I think is not a good thing. But notably, you can see New York Heart Class, particularly Class 3, has plummeted. And as you can see from the survival curves on the right, just looking at the placebo arms in kind of the dashed lines, there have been significant improvements in overall survival in the placebo population not receiving active therapy, which suggests that clinicians in the real world have done a fantastic job at identifying patients at an earlier stage of disease, which is, again, critical to leveraging these particular therapies. And that's reflected, as you can see, in the NAC stage, in which NAC stage 3 has also gone down quite a bit. Same for NAC stage 2 and an increase in NAC stage 1 patients. So I think now we will turn our attention to, if you will, the expert versus artificial intelligence. As artificial intelligence, I think, permeates the world of in general and in medicine, people begin to rely on it, and we thought we'd explore how effective it is at diagnosing and managing what we perceive to be a very complex clinical syndrome. So here we're going to put in a patient who was referred to my center in the AI chatbot and see what they think. This is a 54-year-old man who's referred to our center for genetic testing. He has a brother who has a variant cardiac amyloidosis due to the common Irish variant, so-called ALA60 or THR60 ALA, often associated with a mixed phenotype. And we asked the chatbot, what red flags should we look for in my patient's medical history? And I think you can see here the chatbot gives us some feedback, identifying some key red flags, including heart failure, unexplained hypertrophy, conduction abnormalities, peripheral neuropathy, autonomic dysfunction, cardiac syndromes, carpal tunnel syndrome, and spontaneous biceps tendon rupture, as well as gastroparesis related to autonomic dysfunction and nephrotic syndrome. And the chatbot notes that the family history increases the likelihood of them carrying the same variant because these are inherited in autosomal dominant fashion. And genetic sequencing is seemingly advocated for in this. And they're already suggesting different therapies, interestingly. So maybe, Julian, I guess my key takeaways is it seems to me like the red flags that were suggested by the chatbot are appropriate, maybe not specific for the particular mixed phenotype that we're talking about, kind of just more of a laundry list. Notably, the only testing, which is probably appropriate up front, is genetic testing. Certainly, if the patient doesn't have the variant, the diagnostic likelihood would go considerably down. Treatment recommendations seem appropriate, but I don't know if you have any other thoughts or comments.
No, I mean, I completely agree. I think that, for example, the chatbot mentioned nephrotic syndrome, didn't it? And I can honestly say that I don't think I've ever seen nephrotic syndrome in a patient with T60A associated ATTR cardiac amyloidosis or ATTR systemic amyloidosis, I should say. So I totally agree that it's given a very appropriate list, but not necessarily a specific list without any particular direction towards what mutation it is and what they might be looking out for in detail. I don't think it mentioned erectile dysfunction, which would certainly be an early feature that I would ask a male patient of that sort of age about, because again, T60A very commonly starts with autonomic symptoms in my experience, and erectile dysfunction is often, again, not a specific feature, but is often an early feature of disease in this patient cohort. So that's something that I might add to the long list. But otherwise, I totally agree with you that genetic testing would probably be the first place to go, wouldn't it? Counseling and testing, and because if this patient didn't have a mutation, you'd have made the likelihood of ATTR-CA extraordinarily unlikely.
Yeah, so I completely agree. Again, think about in patients with these mixed phenotypes, focusing a lot more on the autonomic issues initially, and certainly careful history, important, and symptoms. I think it's essential to leverage genetic testing more frequently. We have, at least in the U.S., an issue with family cascade testing. I'm happy to see that this patient is coming in for testing because it has a strong opportunity to identify the predilection for the disorder earlier. If he doesn't have disease, we could continue to screen him. If he does, we can initiate therapy. So This patient, actually we'll put into the chatbot, has a history of bicuspid aortic valve, has concomitant atrial fibrillation, and multiple cardioversions and ablation. So, certainly a pretty significant cardiac history, has bilateral carpal tunnel syndrome surgery and had hip replacement. So we asked the chatbots what we should do during the review of systems. So you were putting the clinical information into the chatbot, asking for what would be a good review of symptoms. And the chatbot elucidates, looking at cardiac issues, neurological, musculoskeletal, GI, and renal, somewhat nonspecific renal findings there. So, I think the chatbot does provide us with some signs and symptoms that are appropriate in general, but again, not very specific for a particular variant we're talking about. And it is important, I think, when you're approaching a patient to be quite knowledgeable about the age of onset of the particular variant, and what are the clinical manifestations, as Julian indicated, that are highly relevant. And that information is usually available from large studies or case series. The chatbot does recommend some imaging, but doesn't specify what should be done. And importantly, as emphasized in the initial talk by Dr. Gilmore, there's no mention of monoclonal protein testing. And so if we're going to pursue a non-biopsy approach, we need to be sure that there's no evidence of monoclonal proteins. And Julian, I don't know if you have any comments, but there are a lot of other red flags, if you will, that I'm not sure the chatbot picked up on in this particular circumstance.
I think I agree. I think we've got the carpal tunnel syndrome, haven't we? We've got that history. We've got atrial fibrillation, which is very non-specific, as you highlighted. But nonetheless, this patient has a significant cardiac history, and I would want to know a bit more about uh, any evidence of orthopedic abnormalities, trigger finger, any other history of orthopedic manifestations. It didn't mention lumbar canal stenosis, as far as I can tell, and that's something that I would certainly want to be asking about, in the history. But on the whole, I totally agree with you. It's produced a list which is reasonable but non-diagnostic. I think as you highlighted beautifully, no mention of monoclonal protein screening, which I think is a real concern, because one can imagine that if one was making the diagnosis on the basis of the chatbot, it would suggest a few scans and nothing more. So I agree with what you said.
Yeah, great. Thank you. So we further utilize the chatbot, noting that the patient doesn't seem to have any symptoms attributable to heart failure, no dyspnea, orthopnea, P&D, bloating, or palpitations, no edema, syncope, denies any symptoms of neuropathy in his feet. These are his vital signs. You can see there, not obese, not volume overloaded. Does have a systolic murmur at his base, consistent with his diagnosis of a bicuspid aortic valve. And so we asked the chatbot, what diagnostic tests should we perform? So as you can see, the chat box says, no symptoms of genetic testing is certainly important in this patient who's got a family history and is at risk, a 50% chance of having the same variant. And then they recommend an echo, bone scintigraphy, and an MRI. MRI, it says, if findings are suggestive of amyloidosis. They note that the bone scintigraphy here should be done in combination with monoclonal protein testing. So it's finally waking up to exclude AL amyloid. So I would summarize, I think the chatbot did a very nice job of naming the appropriate tests, but really no prioritization seemingly was given. None of these tests are, again, specific for this particular variant. EKG is implied as a test, but not explicitly recommended. And finally, as I said, we get to the monoclonal protein testing. So, I guess, Julian, how would you pursue circumstances in this particular, case? Testing, genotyping, what would you do in what order?
So I think we would start very much with counseling and genotyping. And the first thing would really be to find out that the patient either does or doesn't carry the variant. Assuming they do carry the variant with the history that was mentioned, I think we would next undertake an echocardiogram and a DPD scan along with a monoclonal protein screen. And I'm not sure that one would necessarily, assuming the echocardiogram was characteristic of cardiac amyloidosis or even suggestive, if the PYP or DPD scan was positive more than grade 2 or 3, then we wouldn't necessarily undertake a CMR in that circumstance in our unit. And then finally, the monoclonal protein screen, as we mentioned, obviously important to exclude, monoclonal protein. And the last aspect would really be to look hard for evidence of potentially subtle amyloid neuropathy, either autonomic neuropathy or peripheral neuropathy. So those would be the features that we would, the test that we would do. How about you, Matt? Do you agree with that? Are there any things that you would do differently in your center?
No, I completely agree. I would start with, as you said, genetic testing, which he had, and he did carry the variant, and then subsequent testing. So we'd follow just as you would. So we've uploaded the patient's ECG, echo, and PYP scan, and we will ask the chatbot to interpret these results. But let's take a look ourselves at those particular images before we see what the chatbot says. So this patient had the following EKG. You can see they're in sinus rhythm. There's really not definitive evidence of low voltage. There's some leads in the precordial, limb leads that are slightly less than 5, but not consistently. There is evidence of potentially a pseudo-infarct, if you will, in the septal leads V1 and V2 with the absence of R-wave progression, but not an EKG, I'd say, that screams of amyloidosis. The patient had an echocardiogram, which you can see here, still frame images in the middle and the upper right, demonstrating markedly increased wall thickness with a concentric or remodeled ventricle and a non-dilated LV. We can see in the bottom that the patient has a significant LV outflow tract gradient, indicative of their aortic stenosis and bicuspid aortic valve. Though not a very high gradient. And so is this enough to explain the significant increase in wall thickness? Potentially not in a patient with ATTR-60 ALA. And you can see the aortic valve is thickened in the bottom right with an increased Doppler velocity shown by color. And in the upper panel, you see tissue Doppler velocities, which actually are pretty preserved despite the increase in wall thickness. And then this is the SPECT PYP scanning demonstrating diffuse myocardial uptake, indicative of transthyretin amyloidosis in the absence of any monoclonal proteins. So let's see what the chat bot thinks of these particular images. So you can see here it comments on a systolic murmur, somewhat strange from an EKG, does note the increase in wall thickness and the restrictive physiology that's noted in this particular individual. Emphasizes the Perugini scores 2 or 3, but HCl ratio is something that I think has fallen out of favor. But in the absence of monoclonal proteins, this is indicative of transthyretin amyloidosis due to variant disease because of the underlying THR-60 ALA mutation. So I think the key takeaways from the chatbot interaction here are that, again, murmurs are not detectable in an ECG. You need to use a stethoscope. We have another concomitant cause of an increased wall thickness, aortic stenosis. How much is that contributing? Probably clearly not sufficient to explain the phenotype given the positive PYP scan in the absence of monoclonal proteins. I would note that HCl ratios have fallen out of favor, and we don't really utilize them in any decision making at this point. All they tell you is that there's uptake in the area of the heart, but don't tell you again if it's myocardial or blood pool in nature. And again, following the chatbot logic, we did monoclonal protein testing at the end, but we really recommend that be done up front. Certainly, it can comment with any performance of scintigraphy. And so I think we've learned that the chatbot is not so great at interpreting, clinical testing, EKG, echo, and SPECT. It's good news for me as a cardiologist. I'll still have a role. And one study highlighted that chatbots produced comprehensive responses in a majority, but not all, questions on amyloidosis. So use these, I think, approaches of AI somewhat cautiously in your practice would be my suggestion. So again, just to summarize, this patient had a prealbumin level of 20, lower limit of normal in our laboratory, often seen in patients with variant disease. Sometimes their prealbumins are low. His cardiac biomarkers were shown here, indicative of an early phenotype, no evidence of monoclonal proteins, and again, the variant at hand. And so I think we could ask the chatbot what the next step is. So the chatbot recommends a scintigraphy, which we've already done and supplied, so maybe a little out of order. Asked us to assess a vitamin A level, and somewhat confusingly mentions vitamin A levels both with silencers and stabilizers. Maybe we can comment on that in a moment. And certainly is, I think, appropriately recommending starting some form of disease-modifying therapy. So I think, the takeaways from the final interaction with the chatbot is it's not able to really recognize SPECT as fulfilling the scintigraphy requirement. It's in diagnosis. As Dr. Gilmore mentioned, there's really not a need for an MRI. I personally don't, in patients who are on silencers, which can obviously lower TTR levels and reduce the transporting function of vitamin A, measure vitamin A levels, in part because they're always low, even with supplementation. But I don't know what you do, Julian, in that particular regard at your center.
We're exactly the same. I completely agree with you. We wouldn't measure vitamin A levels, which are, as you say, always low. And we've got no evidence, have we, that with supplementation there are any clinical problems associated with TTR knockdown from gene silencers.
Yeah, I think the only thing it does promote is a huge amount of anxiety on the part of the patient, because then they're wondering, why is my vitamin A level still low? So you need to, I think, explain to them that oral supplementation on a daily basis with a recommended daily allowance will, prevent any toxicity from vitamin A deficiency. And unfortunately, the vitamin A levels in the blood are not serologically representative of what the tissues are seeing. And the chatbot, I think, appropriately, maybe in this circumstance, was diffuse about which therapy to pick in some regard. I don't know what you would go for in this particular circumstance at your center, and how would you assess response to therapy, Julian?
That's two very difficult questions, I think it's fair to say. So at the moment, it's not a difficult question in our center because the only treatment that is currently approved or currently funded, I should say, in the UK is tafamidis. If in the event that we had, as you have, all three drugs, I think, in my own personal opinion, and I stress it's a personal opinion, I don't think we have strong evidence that one drug is better than the other. And I think I would base the discussion or the decision about which drug to start on a combination of whether the patient wanted an oral treatment, whether they wanted to take one tablet, four tablets, or whether they would prefer a subcutaneous drug once every 3 months, acknowledging that they would need to be on vitamin A supplementation, which would be a tablet a day. So I think it's pretty difficult at this point in time to direct patients strongly towards one particular treatment. I'd be interested in your views from that perspective, Matt, because you have experience of actually talking to patients about the options.
I completely agree with you. It's wonderful to have three therapeutic options. It makes the interactions with patients somewhat more complicated. They're unfortunately often unsatisfied, and I understand why, with an expert telling them that they don't really know which one's better. But I think the data demonstrates quite convincingly that they're all effective, and you need to get into a process of shared decision making, and there's some nuances. I think most of us would lean toward a silencer for those who had a variant disease with a neuropathy over a stabilizer, but otherwise, I don't know that there'd be any hard and fast rules at this point in time.
Can I ask you a question? Do you have patients asking you to be put on a combination of drugs? And if so, how do you How do you feel about that? And where do you stand on that, as it were? Again, I apologize. I know it's not an easy question, but
Yeah, no, it's a great question. And the short answer is yes. So patients in the States definitely ask, not everybody, but there's a cohort who does. We don't, at this point, endorse a combination therapy, in part because there's no proven data that works together effectively. There is some hint or signal in HELIOS-B in that those patients who were on tafamidis at baseline and received vutrisiran versus placebo had numerically less events, but it was a small subgroup of a few hundred people and no power to detect differences. I don't think cost should be the primary thing, but it is, at least in the U.S., therapies that approach up to $1 million a year when you're combining the two without proven efficacy. So I think we do need to wait for larger either real-world data or emerging data from other clinical trials. But some patients do ask for it, some insist, and if we're able to access it, not easy, we don't stand in their way at this point. So maybe we'll summarize, because this discussion's been great. Again, we have now 3 effective treatments, 2 oral stabilizers, tafamidis and acoramidis, both binding and stabilizing TTR. Acoramidis mimics the super stabilizing Q119 variant. One is once a day, one is twice a day. Neither therapy requires vitamin A, and both therapies are approved in the U.S. for the cardiomyopathy indication, but not neuropathy. And most drugs are very, very well tolerated, maybe slightly more abdominal side effects with acoramidis we've seen, but both doing very well. In silencers, we have vutrisiran, again, approved for both cardiomyopathy and neuropathy. Main side effect is some, injection site reactions, if you will, or some arthralgias. Again, vitamin A knockdown occurs here, and so you need to take a vitamin A supplement. And the mechanism of action here is very different, where it's basically silencing the hepatic production of transthyretin and administered subcutaneously, as Dr. Gilmore said, every 3 months. With regard to progression, I think this is an emerging arena. This was the first paper several years ago based on a group of experts to propose criteria in the clinical and functional biomarker and imaging realm. There's been a wealth of other data, predominantly that emerging from the National Amyloid Center with Julian and Mariana Fontana, demonstrating that many of these parameters are useful, some are not so useful. Particularly, we've learned that there's increases in NT-proBNP, usually of 700 picograms, and 30% are predictive of subsequent unfortunate all-cause mortality. Same with troponin, worsening max stage, New York Heart Class. Functional measures, we've learned probably a 35-meter decline in the 6-minute hall walk, or 5% associated with outcomes, and data emerging even on quality of life measures and KCCQ measured serially can predict outcomes. So we have a wealth of ways to monitor disease progression. We do not know, though, if someone's progressing, that is an indication to do anything differently therapeutically with TTR. I think that's a question that's needing to be addressed, and progression could occur for reasons outside of the biology of transthyretin. I don't know, Julian, anything to comment or add about that?
I think you've summarized it beautifully, Matt, of the current state of play, and I totally agree that it's evolving, isn't it? And we've got more to learn.
Yep, which is great. So, again, we've also learned that through the ATTR-CM, these are recent data looking at cumulative cardiovascular events, that especially early on, there seems to be a divergence, further emphasizing, I think, that there's an importance of early administration of these particular therapies to demonstrably improve the outcomes amongst patients. Similarly, interesting data that just emerged from the Heart Failure Society of America meeting showed that looking at AEs related to GI events and GI involvement is not uncommon, either due to autonomic dysfunction or direct amyloid deposits, that there were significantly less GI adverse events per patient per year in those who received active therapy, in this case vutrisiran, either with hereditary or wild-type disease versus placebo, suggesting some potential clinical benefits on extracardiac manifestations. And as you heard today, there is a real need for an interprofessional and multidisciplinary team. Certainly, neurologists and cardiologists are the quarterbacks, given the predominant phenotypes, but genetic counselors are important, pharmacists, physical occupational therapists, allied health professionals, in particular, in our center, nurse practitioners, to really provide optimal care for a complex group of patients. And as you heard, not all amyloid is TTR. You often find AL when you look carefully, and you'll need a multidisciplinary team of oncologists who have expertise in managing AL amyloid. We didn't talk today much about ocular manifestations, but that's going to be, I think, an important future area, and multiple other specialists in trying to optimize the care for patients. Uh, Julian, anyone I think we left off in this list, or anyone you wanted to emphasize?
No, I mean, I think you've got everyone there, haven't you? And you highlighted the ophthalmologist who, we haven't talked much about, but certain mutations, as you alluded to, are associated with vitreous opacities and vitreous deposits and various other eye manifestations that we need to remember in a patient with hereditary form of ATTR amyloidosis.
And, again, putting it all together, this is a disorder that I think we've come to realize is not as rare as we thought. A high index of suspicion is important. Once you've confirmed the diagnosis appropriately with the right workup, you want to, I think, try to maintain euvolemia, particularly MRAs and SGLT2 inhibitors we learned are quite effective. Be careful with high-dose vasodilators, beta blockers. There are a whole host of disease-modifying therapies now, at least 3 in the U.S. approved, that are available. And again, for those with a variant disease and a polyneuropathy, I think silencers are a favorite therapy. The rest is, as Julian said, a discussion and shared decision-making with the patient about how they want to approach this particular condition. And please do not forget to evaluate for atrial fibrillation. Is quite common, and if they have it, make sure you're initiating anticoagulant therapy to prevent what could be a dramatic or devastating outcome. I guess, Julian, there's probably even some concern your group has highlighted in sinus rhythm. These patients may be still at risk for embolic events. Any thoughts about that?
Yeah, that's thank you for mentioning that, and I think it's certainly a consideration. Is that these patients, as you know, often have very enlarged atria that are hardly moving, stiff enlarged atria, and we are aware from cardiac MRI studies that a proportion, even in sinus rhythm, have thrombi in the atria. So I think one just needs to bear in mind, and I think there's more work to do, isn't there, to establish whether there is actually a role for anticoagulation in certain patients with in sinus rhythm with this condition. But I think there's more work to be done to really establish that role.
And just the key takeaways: the symptoms and severity of ATTR can vary, even among family members within the same genetic variant. Monoclonal protein testing, as we heard, is essential. Please don't order scintigraphy without a monoclonal protein testing. The prognosis of patients has dramatically improved thanks to the efforts of all clinicians who've identified people at the earlier stage of disease, when disease-modifying therapy is most effective. And while we're all enthusiastic about AI and chatbots, be careful out there, and don't forget to use your own thinking caps, so to speak. Thanks again for your time and attention, and I'd very much like to thank my esteemed colleague, Dr. Gilmore, for his fantastic insights and fascinating conversation.
Likewise, Matt, it's been an absolute pleasure as ever to talk and learn from you, and thank you very much.
Same here. So I hope everyone found the activity and the information updating to your understanding of the recent advances in the management and diagnosis of ATTR-CM. I appreciate you very much for your interest in the arena and for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Alnylam Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/UBF860.